A 66 years old right hand dominant man sustained a deep laceration on the dorsum of his right wrist when a glass mirror fell on it. He was evaluated at local emergency and was informed he would need surgery, but he wanted to be treated at another institution. 17 days later, he presented to your office with the complaints that he could not lift his fingers. On examination, you see a 5 centimeter transverse laceration at the dorsum of the right wrist, just proximal to the edge of extensor retinaculum. The patient lacked active extension of the index, long, and ring fingers of the metacarpophalangeal joint as well as the thumb. In addition, he has a lack of extension of the wrist radially. The abductor pollicis longus, extensor pollicis brevis, and the small finger extensors are intact. Sensation and distribution of superficial radial nerve is intact. An X-ray was done previously in A&E, which shows no foreign body and is negative for any bony pathology. What is the diagnosis? Diagnosis is straightforward as a laceration of second, third, and fourth dorsal compartment of the wrist and late presented. Differentials in this situation can be extensor tendon lacerations, rheumatoid arthritis, synovitis, and nerve injury. While going towards the diagnosis, extensor tendon lacerations or rupture that are treated in delayed fashion may not be amenable for primary approximation and repair. Most tendon lacerations and ruptures are best treated acutely, and this is, if not possible, we should be told that reconstruction might be necessary. In case of multiple tendon injuries, emphasis should be placed on recovering independent wrist and thumb extension and mass extension movement of the fingers. Post-operative care is important. Early controlled mobilization, passive digit extension with wrist flexion, and active digit flexion with wrist extension, and dynamic splintage have been shown to have positive effect on tendon healing and ultimate function. Now you are 3 weeks down the line after this injury. The patient is brought to the operating room under regional anesthesia. An X-ray block is given and a tourniquet is applied. An incision is made over the healed laceration and extended proximally and distally. The retinaculum was incised longitudinally over the fifth compartment, reflecting back radially, and dorsally compartments were identified and explored. Extensor carpi radialis brevis, extensor carpi radialis longus, extensor pollicis longus, extensor insidius proprius, and extensor digitorum communis were found to be lacerated. The extensor digitorum communis had retracted proximally and a large gap was present at the laceration. Extensor carpi radialis brevis and extensor carpi radialis longus tendons were directly repaired by a 4-0 repair using a 4-0 non-absorbable, non-braided suture. Similarly, the extensor pollicis longus was primarily repaired. Due to the chronic nature of the injury, however, direct approximation of EIP and EDC tendon created significant tension and did not allow the digit to flex at the wrist in neutral. The decision was made to perform a fractional lengthening of EIP and EDC at the musculotendinous junction, cutting the tendinous portion of musculotendinous junction, after which the wrist could be brought into neutral and fingers can be passively flexed. The wound is then closed in layer fashion over Penrose strain. The patient was then placed in a volar splint with the wrist in 30 degree of dorsiflexion and the fingers in 20 degree of flexion at MCP joint. At day 6, the patient was changed from the static splint to a dynamic outrigger extension splint and began occupational therapy. Dynamic splint was discontinued at 3 weeks' time. Alternate method of tendon reconstruction can be late extensor tendon repair, including tendon grafts and tendon transfers. Harvesting site for tendon graft includes palmaris longus, or in case where the palmaris longus is absent, a toe extensor. If a single digit is injured, its tendon can be repaired with the side-to-side fashion with the adjacent joint. If this is not feasible, EIP is often used to transfer it in a easily harvested and leave minimal defect in the index finger if the EDC is intact. If several digits are affected, transfer of the superficial flexor tendons to the affected extensor tendons can be performed. This is particularly useful when multiple extensor tendons are involved where direct repair is not possible. Boys, and the procedure was later on modified by Neil Buff, takes the sublimus flexor tendon and is rerouted around the radial or ulnar side of the forearm. These transfers provide adequate power and excursion for the transfer of the extensor surface without the need of extensive re-education.